Hi, everyone. Thank you for coming to today's COLA presentation with our colleagues from the BCCDC. We have Jane Buxton and Jessica Xavier here to talk about the Good Samaritan Drug Overdose Act evaluation project that they've been working on for a couple years, which will be really relevant for the next phase of decriminalization that's happening in BC starting in a few weeks. So I'm going to pass it on to Jane and Jess and hopefully have a great discussion afterwards. Thanks.
Thanks so much, Brittany. So yes, Jessica has been a research associate on this project and has done all the hard work and the hard graft. And I am Jane Buxton, the principal investigator on this project. And we're presenting on behalf of also Dr. Alissa Greer, but a much broader research team as well, who have been involved and engaged along the way. I will say, because I'm presenting, I cannot see the chat, so I'm not sure, Connie, if you're monitoring it, or Brittany, if somebody has a question as we go along, can you let me know and we'll try and answer it. But we will be stopping at intervals just to get feedback as well. So this project has a couple of components. One was the Good Samaritan Drug Overdose Act evaluation, which was funded by the BC Ministry of Health. And the other part is a harm reduction client survey, which was funded by Health Canada through the Substance Use and Addiction Programme. And the funders had no input into the data collection, analysis, or interpretation. So first of all, I'd like to acknowledge that this work was conducted on the unceded ancestral stolen territories of more than 200 First Nations across what we call British Columbia. And that BC Centre for Disease Control is on the territories of the Coast Salish people, the Musqueam, Squamish and Tsleil-Waututh nations. Also to acknowledge the thousands of devastating and preventable deaths that have occurred in BC due to the toxic unregulated drug supply. And we recognise the ongoing incredible commitment of people with lived and living experience of substance use who have been and continue to be the lead advocates and actors working to reduce these preventable deaths and reduce the harms for all people who use substances. We'd also like to thank PEEP, Professionals for Ethical Engagement of Peers, for their valuable insights and expertise, and other peers that we've worked with along the way, including Foundry, BCCDC staff and students, harm reduction, distribution and take-home naloxone site staff, and of course all the participants for sharing their knowledge and experience. They really are the experts in substance use and what we need to do to improve the health of folks who are using substances. So the objective of today's presentation is to share the findings that we've had from this Good Samaritan Drug Overdose Act evaluation, which can provide insights, hopefully, about the potential opportunities and also the challenges with BC's broader decriminalization, which is going to be, as you know, implemented as of January 31st this coming year. And we also value your thoughts and insights as we go through this. So a brief outline, I'll give some background information about the Good Samaritan Drug Overdose Act and the evaluation. I think it's helpful to compare the written exemptions for the Good Samaritan Drug Overdose Act and the decriminalization model and what the differences are there. And then share the key takeaways from the evaluation and the implications it has for the model that's coming in. What we've done is we've looked and identified 4 themes, and what we will do is to share the findings under those 4 themes. So the first theme will be lack of awareness and understanding about the Good Samaritan Drug Overdose Act among people who use drugs, among people who are may witness an overdose, and also the police. The second theme is around the limitations of the Good Samaritan Drug Overdose Act legislation and its design, and how it doesn't really reflect how people are using substances. The third is around police discretion and how that shapes how the Act was implemented and contributes to inconsistent applications of legislation, which can lead to distrust of both the Act and also of the police. And then finally, and I don't need to tell this audience, but that decriminalization won't end the drug poisoning crisis. We need to address structural and systemic factors. And then if there's, with time, we'll have discussion. And also at the end of the presentation are some resources and the references, but we won't go into those, but they're there for those of you who would like to see them. So historically, what we can see is that the Good Samaritan Drug Overdose Act was as a result of concerns and information. And in fact, it was an MP from Coquitlam who introduced this. So back in August 2012, we introduced the Take Home Naloxone program. We've had about 1.8 million kits that have been shipped to various sites so that people can respond to an overdose when it happens to somebody that they are a bystander or are there. Despite this and ramping up the program, we were seeing an increase in overdoses and overdose deaths, and a public health emergency was declared in April 2016. What we know at that time was that previous evidence suggests that most overdoses occur with bystanders around, but that bystanders may delay or not call 911 at overdose events for fear of police involvement. And this obviously was a concern. And the first thing that happened to try and address this was that BC Emergency Health Services introduced a policy not to routinely inform the police when an overdose event, when a 911 call was received for an overdose. And we evaluated this and saw that police were certainly attending less over the time. It was always lower in Vancouver of police attendances at an overdose, but across the province it also reduced. And then in May 2017, the Good Samaritan Drug Overdose Act, a federal act, was enacted, and that was to provide some protection from arrest at the scene of an overdose. So when it was introduced, we felt we needed to get the message out, and Health Canada developed posters, and Pivot Legal developed some wallet cards, and BCCDC developed posters and wallet cards as well. We distributed ours to take-home naloxone sites as well as harm reduction supply distribution sites. But we realized that there was a lack of awareness about the Good Samaritan Drug Overdose Act. So what we felt was that we needed to assess people's awareness, and we applied to do the evaluation. And we wanted to understand people's experiences of the Good Samaritan Drug Overdose Act among people at risk of having an overdose, witnessing an overdose, especially youth, because there was a concern that youth may be reluctant to call 911, and among police officers. What we can see here to the right of the screen is the time frame that we happened. So we got ethics approval back in September. We have this ongoing harm reduction client survey, which Brittany has been well involved and really supported us throughout this, and we added a question to it late 2019. We got funding from the ministry in December. In January, we started doing interviews with the police, and we did surveys and interviews through take-home naloxone sites. We analysed what we were finding, and that we had funding that was extended until June 2021. Along the way, you can see those stars. We had a number of meetings with the bigger, larger group. And that included people with lived experience, including PEEP members, youth services, including Foundry, and we had a youth advisory council who gave input with regards to the youth aspects of the study. Folks from public health, medical health officers, harm reduction coordinators, folks at BC Centre for Disease Control, BC Emergency Health Services rep, addiction and emergency room physicians, and also we had some representatives from the police. So you can see that it was a large group who were involved, that we kept bringing back what our findings were to make sure we were on track and what the next step should be. So what we found at the next, this is just really explaining the different components. And what we found was that the quantitative study, which was that harm reduction client survey, so that was at a number of sites around the province where people were going to pick up supplies or access harm reduction. So people were connected to harm reduction services. And what we asked them was what their knowledge was, had they heard of it, and there were some questions around who it applied to, so we could understand their understanding. So that was 2.5 years after implementation. That was in October, December 2019. So it had been around for a while. We also did a survey with Unlocking the Gates, and for those that aren't aware, this is when people are released from corrections. I won't be talking about that, but that has helped us make sure that the information is given to those who leave prison, but also that they get their take-home naloxone kits. We did 22 police interviews, and that was in January, May 2020. And then the bigger evaluation was performing surveys and interviews. We had 453 surveys completed. 106 of those were by youth, aged 16 to 24. And we did some interviews. We had 42 interviews, of which 14 were with youth. We had planned to do focus groups to reach even more folks, but this little thing called COVID came along, and that made it harder to do focus groups. But we were pleased to manage to enroll and get as many surveys and interviews completed as we could. And that was happening 3.5 years after the Good Samaritan Drug Overdose Act had been implemented. So it wasn't really immediately afterwards, it was some time afterwards. As I promised, this is really sharing more detail around the comparison between the Good Samaritan Drug Overdose Act and also the BC decriminalization model. So the Good Samaritan Drug Overdose Act is federal, so this is for the entirety of Canada. It was implemented in May 2017 and is ongoing. Whereas the BC decrim model, it's happening just in BC under a federal exemption, and it will be implemented January 31st, 2023. And the exemption is there until for 3 years. So we will see, hopefully with evaluation, that it will continue or may adapt accordingly. So the objective of the Good Samaritan Drug Overdose Act was to reduce overdose deaths by reducing concerns around calling 911, to encourage people, if somebody was having an overdose, to call 911 and to get paramedics there to deal with the medical emergency, and not to worry, to reduce concerns about police. The objective of the BC decriminalization model is more to reduce stigma around drug use and concerns around criminalization, in the hopes that this will encourage people to access healthcare and other services without fear of repercussions. There are some differences in when it applies. The Good Samaritan Drug Overdose Act is for people who are experiencing or witnessing an overdose event. So that's whether they stay or leave the overdose, leave the scene. It's for simple drug possession, in other words, possession for personal use, but no threshold was indicated. It also includes violations of pre-trial release, probation order, and conditional sentencing or parole when it's related to drugs. These are drug offences related to simple possession, and it applies to all ages. And it's with the BC decriminalization, I think we're all aware that there's no restriction to an overdose event, but there is a cumulative total of 2.5 grams. So that is what its simple possession is defined as under the decrim model. No mention of violations, and it's for adults or aged 18 and over. And when it doesn't apply, obviously, for the Good Samaritan Drug Overdose Act, it's other offences, trafficking or suspected intent to traffic, outstanding arrest warrants, offence other than simple drug possession, and violations of pre-trial release and probations. The decrim model is not applied if somebody has more than 2.5 grams. If drug trafficking is suspected, and also geographically in areas surrounding elementary and secondary schools and childcare facilities and in airports. So I'm hoping that gives you an idea when I say what we found with the Good Samaritan Drug Overdose Act, we can see how it may apply to the BC decrim model. So you may remember when I started the presentation, I gave you the 4 themes, and I'm going to talk about the first theme, and then Jessica is going to take on the other 3 themes and wrap it up. So the first theme was lack of awareness and understanding. And this was among people who use drugs, others who may be witnessing an overdose, and the police. And of course, we need to remember that an act like the Good Samaritan Drug Overdose Act is only as effective of people's understanding and awareness of it. And in summary, we found considerable gaps in awareness and understanding among the public, but also the police officers. So this is from our harm reduction client survey, which was rolled out in 2019. As I said, this is 2.5 years after the Good Samaritan Drug Overdose Act was implemented, and despite trying to get the message out, only about half of people were aware of it. So these are people who are attending harm reduction distribution sites where there have been posters, there have been communication, but there was still only half folks were actually aware of it. About half of those who were aware had a complete understanding of who was protected, but it was only 1/3 that had a complete understanding of what and when the protection occurred. So this is, I'm going to give you some quotes, and I'm not going to read them all, but I think what we found and was concerning was that people who use drugs seem to overestimate the legal protections provided. And of course, this may be an issue with decrim as well. So the Good Samaritan Drug Act, Good Samaritan Drug Overdose Act, you don't have to worry about when you phone if there's an overdose. They won't ever check you for drugs. They'll never charge you. You won't be searched. You won't be charged. You won't be taken away. And I think, as you saw in that table, there were quite considerable limitations to when it does apply. Another concerning piece was around police officers and their knowledge of the Good Samaritan Drug Overdose Act. Many couldn't really articulate when and for whom it applied, and many also underestimated its legal protections, different from people who use substances who seem to overestimate. And with some quotes here, I know actually very little about it. I've heard of it and knew it would protect the user. I didn't know about callers and things like that. And I think the third quote is something that was a good message for us, was that it went out in some sort of email saying that the law has now changed and make sure you know this, which probably didn't have a whole lot of impact. And in response to these findings, we gave reminders to folks who use substances through posters and reminded the sites that there were posters and things available, and also the RCMP developed training presentation for roll call and a refresher. And I'm just saying my green thing around my screen is not showing up. Are you actually seeing my presentation correctly?
Yes.
Brilliant. And I can see a hand up. I can see Kat has got her hand up.
Hi, yeah, thank you. I just put in the chat. I was just curious, like, what about, because I've heard, I mean, if somebody is on parole or probation with restrictions or have warrants and they call for an overdose, people have been arrested.
It all depends on what the restrictions, what the parole probation is for. If it is for simple possession, then they should not be arrested. But if it is for trafficking or other offences, then potentially they can be. What we heard was a lot of police, and we'll talk about this, Jessica will talk about it in a bit, around police using their discretion. And that doesn't always, and obviously, as you can see here, there was a lack of understanding around what the Good Samaritan Drug Overdose Act actually covered, and the police weren't always aware. David.
Yeah, hi, thanks for having me. I think it could also affect whether the police would follow through with charges depending on how a person would treat the police. As well as I've seen people too afraid to call 911 as of because they end up in 2 cities away at the hospital with no way to get home, or they've got stigma against the hospital, or they've felt judged, or some, like, everybody's different, right? But we all have had our own like negative experience. Well, not everybody, but some people have negative experiences in emergency, and then you go to the hospital, they save your life on the ground, then they bring you to the hospital unless you refuse, and then they cut you loose and you just sit there on the knot and you fall back into like my personal thing. I fell back into overdose just down the road and had to get ambulance back again. And then I sat there for so long until they bought me a cab back to the negative area which I was at. So
Thank you. Thank you, David. I think, you know, there are many reasons for not calling 911. I mean, we were looking at really, was it an issue that, did people realize that the police could not arrest you for simple possession? And what we found, folks who use substances, not everybody knew about it or really understood it. So what we're trying to imply is that when we look at decrim, it's really important that there needs to be good education and knowledge to make sure that the public, folks who use substances and the police actually understand when and when it doesn't apply. And, you know, people need accurate information so that they can effectively advocate for themselves and for others, because if they find, you know, what they expect isn't what happens in reality, and as you mentioned, police may arrest an individual, then that creates mistrust in the police and also around the act itself. So that's really what we're saying. And just to finish off this section is that the police really need comprehensive mandatory training with regular refreshers and knowledge assessment. They were sent an email, most of them probably read it or didn't take it in, but with decrim, it's so important that we have to make sure that the police are aware, and that's part of the training. So thank you for those comments, David. And I can see Amy has her hand up.
Yeah, thanks, Jane. I just wanted to add as well, as a staff and as a staff nurse on site, what I see happening a lot is we're calling paramedics for an overdose, and paramedics have been calling the police. So even though we're not getting like, I have so much respect for our EMS services, but the amount of times that police are being called has deterred a lot of folks from wanting us to call 911 in general. And it puts a lot of staff in a really challenging situation where we have a policy for our agency to be calling 911 in any overdose. And then we've got our program participants that are afraid to have the police show up, and it brings up a bigger point of paramedics and making sure that they're being empowered to know about this as well. I think the police being aware of it is obviously really important, but I think any emergency medical services, fire department as well, because very often they're the first on scene, even before paramedics, right? So I just wanted to throw that in there.
So the actual the policy that was introduced by BC Emergency Health Services is actually at the call, where the calls come in, that they don't automatically refer. The times that they do is obviously if there is a death, or somebody has attempted suicide, or there is concern for safety, and that safety is of the folks who are there, but also can be of the paramedics. And of course, paramedics can be concerned if it's in a particular place. They may say they want the police to come because they don't feel safe. And that I think we see happening, you know, not so much in the downtown east side, but certainly in other regions as well. So Tanis, if I'll take your question and then I'll hand it on to Jessica for the next piece of the presentation. Thanks. Tanis.
Hi, everybody. Sorry, I just got out of the car. So Tanis here from Stalo, Coast Salish Territory and Mountainside Harm Reduction Society. I just have a relevant question. It's kind of like parallel relevant though. Basically, one of the problems I see with Good Samaritan Act is that people are still getting like massive ambulance bills and they're chasing them around forever and ever, and it's going to collections if there's no fixed address. I know it's not like a part of the study, but yeah, just something to note.
Yes, thank you, Tanis. I think we have brought this up before, and there's been discussion about whether it's the individual or whether it's the person that called. That has increased some of the reluctance to call. But I think this is probably something that, aside from this, that we should be following up with and to actually get some clarification. So thank you so much for bringing that up. So I'm going to hand it over to Jessica now to address the next slides.
Thanks, Jane. Hi, everyone. My name is Jessica. I'm the research associate at the CDC.
So it's on the strip, but we couldn't even detect it.
So
it could be an analog too.
Yeah. So I think there may be someone who's not on mute. Oh, there you go. Awesome. Okay, so I'm going to take us through the next three takeaways from the study. I apologize, my camera's not working today. And as life has it, there's a convoy that started outside my window as this presentation started. So hopefully you can hear me, and I'm sorry you can't see me. So the second takeaway from the Good Samaritan Drug Overdose Act evaluation was that how the actual act or the legislation is written has considerable limitations. And this has to do with the legislation not being aligned in some ways with the ways that people use drugs and sort of the realities of people's lives. And so people shared a few ways that that the act didn't align with how people use drugs. Was that confiscation was still something that police could do under the Good Samaritan Drug Overdose Act. So even though it protected for simple possession, people could have their drugs taken away. People could be arrested for drug trafficking. And as Jane shared with the Good Samaritan Drug Overdose Act, there's not that clear threshold distinguishing between simple possession and drug trafficking. So it's really based on what evidence is considered sufficient for a drug trafficking arrest. And then people with a history of involvement with the criminal legal system are not protected. So if someone had court-ordered conditions, so for example, they were the court kind of ruled that they shouldn't be using, that was not protected, and if they had any warrants or anything like that, that wasn't protected under the Good Samaritan Drug Overdose Act. So here's the table that we had in one of the first slides, kind of outlining when the GSDOA applies and doesn't apply. And if we look at where it doesn't apply, it leaves out a considerable number of people and situations who aren't protected by the GSDOA. And some of these quotes speak really well to that. So for example, someone said, if I have a half ball on me, I can probably get charged for something other than personal possession. So trafficking here. Another person talked about, I had 3 people overdose in my room. And when they came to my room, the cops tried to investigate me for trafficking. So people using together, and then that sort of being seen as evidence for trafficking because there's maybe a larger amount of drugs or just more people together. Similarly with this third quote where the person is talking about crack shacks or houses where people are using together. And also people with any kind of history of criminal justice involvement. So in this last quote, the participant talked about they had a warrant. And so even if they were protected for simple possession, they left the scene of the overdose because they were concerned about that warrant. So what does this tell us? It tells us that the way legislation is written isn't always aligned with kind of how things are in reality. And so, for example, people use together. Sometimes people buy in larger quantities. So if we think about rural areas or people who just want not have to go back for smaller amounts all the time. And the way that the legislation is written is that it still sort of criminalizes these people. And this is obviously applicable to decrim because we've heard similar concerns with how the BC decrim model is written, being flawed or having some issues for some people. So the low cumulative threshold, putting certain people at risk of being arrested for intent to drug traffic. And then also just a lack of legal protections for people with certain vulnerabilities. So people with conditions and warrants, but also like people who are unhoused or precariously housed. So with decrim, we know that the public consumption isn't legally protected and that still falls under city bylaws. So it puts people who are unhoused and who may not have another option other than public consumption at risk. The third takeaway from the study, and Jane mentioned it and a few of the comments spoke to this, was police discretion. So the way we're defining police discretion is the freedom to decide what should be done in a situation. And so police having this freedom to decide what should be done and interpret the GSDOA shaped how the GSDOA was implemented and contribute to inconsistent applications of the legislation, which when we did interviews with people who use drugs, we then heard kind of impacted their trust in the act and in police. So I won't spend too much time on this graph here, but just to show, we asked people who use drugs in the Good Samaritan Drug Overdose Act survey at the last overdose that they were at, if police were present, what did they do? And this just shows the range of police actions at the last overdose event, despite the GSDOA. And some of this may be circumstantial, so depending on what was happening at the overdose event, but some of it is likely due to discretion. So you'll see that 70% were taking a bystander or medical role, but there was still this 30% that was doing some form of law enforcement action, whether that was searching people or checking people for IDs or warrants or making arrests. And so discretion, what we heard from both interviews with police, but also interviews with people who use drugs, was sometimes used for less punitive action. So we heard from police that they chose not to arrest for simple possession before the Good Samaritan Drug Overdose Act came into effect in some circumstances. But discretion was also used to to be more punitive towards people who use drugs, or to sort of interpret the GSDOA in a way that police wanted to. So for example, we heard about police finding someone after the overdose event and arresting them at a later time, defining when the overdose event starts and ends. So in the legislation, it says, you know, simple possession is decriminalized at the scene of an overdose event. And so police questioned, well, when does that overdose event end? And some people talked about police arresting when they saw it as ending. And just police using their discretion to interrogate and arrest. And so I'll read two of the quotes here, but one of the police said the law tends to be gray because that's how it works the best around interpretation. So I think that's the way these sorts of laws should be developed. It's more up to the individual officer how they kind of see themselves applying these sorts of things. And then on the flip side, hearing from someone who uses drugs, they said the act means it's something on paper to appease the public and appease Parliament and whatnot, because when it comes down to it, it doesn't mean jack shit. When a cop pulls up on you at an overdose and you have dope, you're going to jail. So we see that like lack of trust because it depended so much on the police officer. And some of the main ways we heard about police using their discretion, like I said, was around choosing to do police action. So some police thought it was necessary to check for IDs or search for warrants and all of that at an overdose event. Others didn't. But also around drug trafficking. So because there was no distinct threshold between simple possession and drug trafficking, police were using their discretion to determine when people were trafficking, and that made some vulnerable. So people who were low-level drug traffickers, those needing to buy larger amounts for personal use, and people using together, like I mentioned in an earlier slide, to be safe, but some of that could be interpreted by police as evidence of trafficking. So in terms of decriminalization, I think the same applies in terms of police discretion. So there's an author who says the law in the books is not the law in the street. And so the law isn't always applied in practice as it was intended. So kind of beyond the limitations of how decrim is written or the legislation, the added variable is how police are going to implement it. And for that reason, it's important with decriminalization that we're monitoring arrests, not only around simple possession after decrim is implemented, but any kind of arrests in the context of drug policy or criminalizing people who use drugs, because you know, some arrests could go up if the tool of arresting for simple possession is no longer there. And the last takeaway for the evaluation was broadly that decriminalization won't solve the crises, and crises here is plural because it won't solve the drug toxicity crisis, but also these other crises that play into stigma and access to healthcare and some of the objectives of decriminalization. And so there needs to be pushing on multiple fronts, including regulating the supply, but also addressing issues like the housing crisis and profiling people, or police profiling people, and a number of pieces. Yeah, and so structural and systemic factors need to be addressed beyond decrim. And this really came out in the GSDOA because while the GSDOA aimed to encourage people to call 911, there were people who still had considerable concern and who mentioned that they wouldn't call 911. And sometimes it had to do with these other marginalized or criminalized identities. So people who identified as Black, Indigenous, or people of color, sex workers, the GSDOA didn't sort of protect them and there's some powerful quotes here. So one participant said, being a person of color, a lot of people that I used with being people of color, when it comes down to it, we have to contact the cops. That's like last resort. Even given the Good Samaritan Act, you get treated differently. We could go into the semantics of brutalization of minority communities by police, but it's kind of common knowledge at this point. And there's the Equity is Safer report that came out, and we see that certain groups are over targeted in BC. And similarly with sex workers, there were concerns there that weren't addressed by GSDOA. There was also police perspectives and practices that aren't addressed by the GSDOA. For example, coercion or police attempting to force people into treatment. Someone mentioned earlier, police driving people out kind of in the middle of nowhere and then them having to find their way back. Like, these are all practices that could continue despite the GSDOA. And then just generally, the GSDOA didn't address the various ways people who use drugs are criminalized and beyond simple possession. So one participant said the nature of drug use these days is that it's kind of criminality goes hand in hand with a lot of people who are chronic and habitual users. So when you have that added element, if you're partying with lawyers all weekend, somebody overdoses because they're on their weekend cocaine trip, I think that they would be more likely to call 911 than someone who has criminal involvement. And this is all really important to keep in mind when we're thinking of what decriminalization can achieve. So just thinking about decriminalization not addressing the toxic illicit drug supply, and also not necessarily making services and service providers safe for people who use drugs. So decriminalization isn't making services necessarily more trauma-informed, more person-centered, more culturally safe. And so these are all pieces that need to be addressed in parallel with decrim. And then, of course, we need to be coupling decrim with a regulated supply of drugs if we want to effectively reduce stigma and recognize the rights of people who use drugs and the drug poisoning crisis, and disrupt the link between drug use and criminal activities that exist because people are forced to acquire purchasing power, but also can be denied employment opportunities and all those kinds of factors. So just to summarize, implementation matters. So drug laws and policies are only as good as knowledge and awareness of them among the audience they are intended for. And Jane talked about the low awareness we saw with the GSDOA. The details matter. So the model features can undermine the aim of the policy, including threshold amounts that defines personal possession, ability to seize or confiscate, not having legal protections for people with criminal justice histories. So all of that. The law in the books isn't necessarily the law on the street. So police discretion does play a role. And so we need to be monitoring police discretion and how decrim rolls out in practice or in real life. And then decriminalization does not address the drug poisoning emergency and systemic issues. So under decrim, people continue to have to rely on unpredictable toxic supply of drugs. And then there's these other systemic issues that can kind of still contribute to stigma and lack of access to services like racism and discrimination, coercive treatment, and some of those pieces. And I'll leave it at that. I think I'm assuming we have time for questions.
Yep, thanks, Jessica. So we've got 10 minutes, 12 minutes for questions, and we really welcome your insights and your wisdom. And as I said, we've just got some of the resources, and you can find most of these on towardtheheart.com. And then there's a list of references that you can take a look at as well. But that's our presentation, and let's open it for questions or comments or sharing your experience. Does this ring true for you? Is there what concerns folks have? on the findings from the Good Samaritan Drug Overdose Act and the applicability to decrim. So I will open the floor.